Welcome to the CBIA BizCast powered by Google. On this podcast, we dive into stories about Connecticut businesses.
Downs Construction actually came to my school.
And business leaders.
I think it's always also really important to be able to see a path forward
for shaping the future of Connecticut's economy.
Thanks for joining us for the CBIA BizCast. I'm Paul Pescatello, CBIA Senior Counsel and Executive Director of the Bioscience Growth Council. This week, we continue our two-part discussion on the important issue of whole genome sequencing. This week, we bring you a conversation with Dr. Adam Matson, a neonatologist and lead researcher for genomic sequencing in neonatal and pediatric populations at Connecticut Children's Hospital, and Dr. Louisa Kalsner, Division Head for Genetics at Connecticut Children's. So welcome. We're pleased to be joined today by Dr. Louisa Kalsner and Dr. Adam Matson. Dr. Kalsner is a pediatric neurologist and Division Head Genetics at Connecticut Children's Hospital. We're also joined by Dr. Adam Matson. Dr. Matson is a neonatologist and physician scientist at Connecticut Children's Division of Neonatology. He's an expert in neonatal intensive care and director of Connecticut Children's Biorepository. So let me begin with Dr. Kalsner. Tell me just a bit about your background and what you do, your research and your clinical practice.
Well, I am a child neurologist and also a geneticist. So I initially trained in pediatrics and then decided to go into child neurology and had a little gap in time and had an interest in genetics. So did a genetics fellowship training mostly between those two. So for years, I've, focused on treating kids with neurologic diseases that are genetically based. I do general neurology practice, and then in more recent years, shifting a little more focus to genetics. Now I'm division head of genetics at Connecticut Children's Hospital, but still focusing primarily on neurologic diseases, of which there are many with a genetic origin and genetic basis.
Dr. Matson?
So I provide care to newborns in the neonatal intensive care unit at Connecticut Children's. And those are newborns that are born with a variety of different medical problems that range from prematurity to infectious concerns. They may be born with congenital malformations or have genetic syndromes that require specialized neonatal care.
And so there's a diagnostic odyssey that parents and talk about with their kids in terms of identifying what's when there's an issue, when there's a problem, that it can take years to figure out what's the underlying cause of disease. So talk a little bit about that diagnostic odyssey and then how whole genome sequencing fits into the picture.
Yeah, I mean, so I see patients, that are newborns from the neonatal ICU, maybe even preemies, on through adult age, usually people in their 20s, maybe, rarely above that. But so a big, broad range of ages. And there are absolutely so many, children who have what we think is a genetically based, condition, and we struggle to identify it. Also, for a lot of the older, teenagers and young adults, this kind of genetic testing was not available when they were young. So a lot of people, families will circle back and, we can make a diagnosis in someone who's 22, and the families have been, waiting and wondering all these years.
So before there was genetic testing, how did diagnosis proceed?
I mean, there's been genetic testing. It just keeps getting more and more sophisticated, so I think even during the course of my career, we used to focus on looking at the patient, trying to recognize a pattern or a syndrome, and then trying to pick the gene that we wanted to test and testing that one gene, which is really hard. And as we've gotten better with this testing and realized that there's thousands of genes that are, important in development and brain development alone, it's impossible to recognize all these different conditions. A lot of them look the same, but they're caused by different genes. So I think it's really shifted. Now we tend to do the genetic testing and look back and try to match it with what we see and see if it fits together and makes sense.
So what exactly is whole genome sequencing?
Well, whole genome sequencing is a very big test that essentially is able to look at the person's DNA. So, we have DNA in each cell in our body that is packed with genetic information, and whole genome sequencing is a test that is able to spell out the whole genetic code a person has and try to figure out what differences are there that are important and might be causing symptoms or problems for that person.
And so it can give you a very specific diagnosis. I mean, and a definitive diagnosis.
Yeah, absolutely. Like, for instance, you can see a child with developmental delay, and there are thousands of potential genetic differences that could result in the same kind of symptoms. But the genetic test lets us get to a very single specific genetic difference. And that's often really helpful because especially for some of these differences that we know more about, with a specific genetic diagnosis, you might have developmental delay, but also, cysts in your kidney or, potential for an aneurysm in the aorta. So I think much of what we can learn from that is really how to better take care of the patient, the child.
So you could really hone in on exactly what's the problem, as opposed to taking, and it truncates the time that it takes.
Sure, and it guides us really in how to better take care of that person in the long term, what kind of things we need to be monitoring. Helps us advise families if they're having more children. Is this something that, that might happen again? Helps us figure out if there's any treatments available. And so I think we're getting a little better at treating some of these differences as well.
So Dr. Matson, so when's the best time to use whole genome sequencing?
Certainly when clinical concerns arise, and many of these problems or questions confront these families and children right after birth. And so we actually see a lot of these infants that are admitted to the neonatal intensive care unit. And as Dr. Kalsner was saying, the technologies and the improvements really over the last 10 to 20 years have really revolutionized genomic sequencing to help diagnose these problems. Years ago, we were looking at just groups of genes and sort of kind of picking out of a hat in order to try to identify things. As the technology has improved, we've gone into doing something more commonly now in the clinical arena, what's referred to as whole exome sequencing. Okay, and so if you think about the magnitude or the volume of DNA in a human, which is 6.4 billion base pairs. Okay, it's a real tedious challenge to analyze all that sequencing data. And what whole exomes does is it really trims that down and looks at 1 to 2% of the DNA that's really responsible for transmitting the genetic code. And the majority of genetic disorders are in those regions. What whole genome sequencing does, as opposed to whole exome sequencing, is to expand that even further and include not only those coding regions, which are referred to as exons, but to also include the non-coding regions. And so you're looking at the additional 98 to 99% of the DNA. And there's a number of different conditions that are being found in those non-coding regions, type 2 diabetes, coronary artery disease, different cancer susceptibility genes, and genes that may be related to development. So implementing whole genome sequencing is something certainly that we're looking to do more often at this point in time. But I will admit that it's still an area that we're trying to sort of figure out how it relates to the clinical phenotype of the
how best to use it.
How best to use it.
And how is it done? What is how you take a sample? Is it a blood sample, cheek swab?
Yeah, usually it's a blood sample, and we could also take a cheek swabs. And ideally, if you're doing that, we try to do what's called a trio analysis, so that you're looking at both the patient and parents as well. Okay, and then those samples get sent and DNA is extracted. Okay, and then they get put on sequencers, and
But the sequencer is what? Is it black box? Is it a room? Is it a room of?
They're usually, so they're actually pretty incredible, because some of the sequencers now have gotten to the point where they're almost as big as your cell phone. Okay. Now, whether or not those are as accurate as the big sequencers is still up for debate. Okay, but I would say that some of the best sequencers right now are about the size of this table. Okay, again, when you're looking at 6.4 billion nucleotides, it's a lot, and then interpreting that data is also a big deal.
It's a vast amount of data.
Yeah.
So that was my next question, really. How do you sort through that data? How do you do triage, so to speak, on the data?
Typically, we're sending this out to a lab that is experienced in whole exome sequencing, again, which is the more commonly sent test. They have big teams that analyze. It's a difficult task, actually, because we all have thousands of differences in our DNA.
But whole genome sequencing, you're looking at, I have in my notes here, 3 billion variants. I mean, I think you might have, Dr. Matson, you might have said something like 6 billion.
In terms of base pairs, 6 billion base pairs.
20,000 genes in the genome, usually, you think. Yeah. And we don't understand what more than, 5,000 of them do, I think. So we're still in the dark about a lot of it.
Yeah.
So it's not like, obviously, if we all had one genetic code, we'd all be clones of each other. So we all have thousands of differences, and they end up with this big mound of differences, essentially. And the hard task really is trying to pick through those differences to figure out what differences are actually causing disease or causing a problem, and which ones are normal person-to-person differences. Sometimes they
flag some of the most important differences.
Yeah, usually they're tiered, so there are differences that we know cause a problem, what are called a pathogenic variant. And they'll know that exact difference has been found in other people with disease, and the lab will state clearly, oh, this is positive because there's this pathogenic variant. But often they may return back a bunch of differences that are maybe important. They have ways computers try to guess if they're important. They look at if parents are carrying them, look at how the symptoms are lining up with what we described. But often, they'll report back a few differences that they call uncertain. And then we try to figure out, how those fit and do they make sense? And sometimes over time that becomes more clear. So I think we're still in a big learning, steep learning curve with genomic testing, and the labs are, and the databases are growing, and we're discovering genes all the time.
So why do you do, you said you do the parents, that you do siblings? I mean, so what's the value of, when you're trying to hone in on what's causing a disease in a child, why would you do the parents or the children, or the siblings?
Well, I think it makes that task of interpreting the data much easier, because much of what we see causing significant disease in childhood are differences that are what we call de novo, so they're new in the child. So mom and dad are healthy, they don't have any of these symptoms, and the child is very sick. Usually we're not looking at a difference that both parent and child carry, though there are definitely exceptions to that. But most of the time we're looking for a new change in the child. So it really helps the lab right away to kind of bubble up and see what are the differences in this child that the parents don't carry.
Comparison is valuable.
Yeah, so it kind of takes, siphons down a few changes out of this huge mound of changes they found.
So what is rapid whole genome sequencing compared to whole genome sequencing? So as I understand it, whole genome sequencing takes about 50 hours. Is that, I guess rapid whole genome sequencing takes about 50 hours versus 10 to 12 weeks for regular whole genome sequencing. Is that?
Yeah, I think that's the main difference is how much resources the company is putting into getting the results out as fast as possible. Usually within about 5 to 7 days, we're getting results back for rapid, where the standard may take 6 to 10 weeks or along those lines. There's also a difference in price for those as well.
So, we use the rapid testing really in the inpatient setting. I've never ordered it outpatient because usually things are more stable, and typically, we can wait a couple months to get the result. Inpatient, people are sick, obviously.
This would be a newborn.
Could be a newborn, could be a child that came in and got terribly sick and we don't really understand why, or a child that people have suspected has a genetic difference, but they never had testing and they're sick now, and we're trying to understand how to take care of them. So, we send probably, it depends on the week and the month, and what's going on, but usually, we might send a few of those in a week.
But sometimes it could be life and death, right? I mean, you have a newborn and you're trying to figure out. And
Absolutely.
So before there was whole genome sequencing, an infant could have died, in the hospital. But because of the speed that you can find out what's going on genetically and hopefully find some kind of treatment, it can mean the difference between life and death. Is it?
Yeah, it certainly can. I mean, there are some instances where, getting those results can alter treatment and maybe change the medications that are being provided, or inform the clinical team to maybe do other diagnostic tests, or even make the patient eligible for a clinical trial that they would not have been eligible otherwise. But many times it's also trying to provide some answers, right, to the clinical team, to the parents, about why something is happening. Why is their child so sick? What can we tell them about prognosis? And it certainly may have implications on family planning down the line as well. As physicians, we're trying to look at molecular reasons why disease occurs, and unraveling the genetic basis of specific diseases really helps us to ultimately provide the best care, I think.
So I was trying to just think of a couple of children I've taken care of where the test really was important, the rapid test, ones we sent inpatient. And one is a little baby, that 4-day-old baby that came into the emergency room with seizures. And there's lots of causes for seizures in babies. This baby was having a lot of seizures, got a lot of medication, ended up being on a ventilator in the intensive care unit. And there was a lot of difficulty getting him off a ventilator and getting him then to feed on his own and off of oxygen. So everyone figured there must be an underlying, severe problem here. There's a lot of severe we call infantile encephalopathies that can have epilepsy and, really impact development, and kids struggle with epilepsy long term. And we sent the rapid exome sequencing for him as well. And it came back actually showing a difference in a gene that causes a really not bad situation. It causes something called, what we used to call 5th-day fits, which is sort of seizures right around the 5th day of life, exactly when this baby presented. And the good news is that babies tend to outgrow that and do very well. So everyone was just a little patient, and he started feeding, medicine levels came down, feeding tube came out, and baby did great.
He had a definitive answer.
Had a clear answer that helped us not put a feeding tube in, and so it really did help kind of get an understanding of what was going on, and certainly changed care for him.
What's the cost of whole genome sequencing?
Again, there's not a set price for these tests, because different labs charge different amounts. I think sometimes there's different contracted rates, so it's hard question to answer, and I don't know all about the cost. Again, so we send a lot of whole exome sequencing, which Dr. Matson talked about is the test that's still a very big test, but a little bit more limited in that it focuses on looking at the genes, the coding parts of DNA. And that's a test that we've been able, to access pretty well in the last, 10 years or so, outpatient and more recently inpatient. The cost is several thousand for sure. Sometimes a company might bill $8,000 or $9,000 I've seen, and sometimes it's $3,000 or $4,000. And sometimes if families want to pay out of pocket because their insurance won't cover it. So it's sort of a little bit all over the place.
But it's come down drastically in cost, right? So 10 years ago, we would have been talking in the tens of thousands of millions of dollars for just one sequence.
I saw somewhere in 2010 it was about $50,000. Yeah. And the thing about it is there are numerous companies that are doing this now, are providing the service, and the technology is getting so good that I think that there's a race that's kind of going on from a technology standpoint that's helping to drive the price down.
So at the end of the day, does whole genome sequencing save the overall healthcare system money? It seems, because it seems like prior to whole genome sequencing, you could do lots of tests, see lots of practitioners to try to figure out what's going on with a child. And now you get a pretty definitive answer quickly.
Yeah, I think that's accurate. I mean, you had mentioned a term before, the diagnostic odyssey, and that's accurate in that many of these individuals have had years worth of testing and to try to find an answer. And ultimately, it has scaled up because years ago, as we mentioned, whole exomes were $50,000 to do. So they were, that was a last resort. But then if you looked at all the testing that they had up until that time, it could have maybe added up to almost $15,000. Now, as the price of it has gone down, certainly putting it in as first line, testing makes a ton of sense.
Much easier for the patient, because we used to do blood tests and urine tests and more blood tests, and then sometimes we would do spinal tap, for instance, which that requires anesthesia so often, and it was painful. There can be complications. Or we do muscle biopsies. It was much more common for kids with muscle weakness or muscle disease to do a muscle biopsy, which is a whole surgery. And so really the cost is, if you compare even one procedure, not to mention what the patient has to go through, because outpatient, we do this with a cheek swab, and it's nothing.
Very simple procedure.
It's nothing. It takes 2 seconds. It's easier than brushing your teeth compared to what we used to have to do. It's really dramatic.
So how do you go about authorizing whole genome sequencing? I mean, is this something that you stop and have to seek approval for, or is it just if you find in your clinical expertise that this is required, you just do it?
Yeah, so this is so I actually call her up when when I'm wanting to order it, and because she's the clinical geneticist, and she's excellent at following these patients. But certainly if we have infants that present in the NICU that we have a strong suspicion they're critically ill, we think it's important. It's a team approach, and we sort of gauge what we think the yield would be on these tests, and usually we're all in agreement that it's important to send them.
And so you just do it, and so who ultimately pays the cost of it? I mean, so is it the patient's insurance? Is it, as I understand it, the hospital, Connecticut Children, just covers the costs?
I think this is different inpatient and outpatient. So in the inpatient setting, and I don't know everything about the billing, but I know the bundling of care, the insurance we can't bill for each thing we do. So when we send these tests inpatient, whether it's whole exome or whole genome sequencing, the hospital essentially pays that bill. So we have to be a little careful so we don't bankrupt the hospital. So we try to use it in situations where we think it's important for the kind of immediate care of the child, and to help us understand how to take care of the child. And that comes up quite a bit, as a fair number of kids, as I said, often it's a few in a week that we may send. The outpatient setting, we go through insurance, or someone could self-pay. Again, that price is coming down, so sometimes insurance doesn't want to cover it, or it's going to be a lot of money through insurance, and it's cheaper to pay. So it still takes a lot of navigating, and we try to get an estimate in advance, and then there's various protective barriers to make sure people don't get a big bill, where the genetic testing company will let the family know the cost before they run it.
Is there much pushback though from the payers, from the insurers?
Absolutely.
And so why would that be? If it saves money and it's the state of the art in terms of diagnosis, why is there pushback?
It's still several thousand that they pay. Sometimes I'll notice insurance companies get billed thousands. They get a big bill from the genetic testing company, and it depends on their contracted rate. I guess what I experience often is there's certain situations where they will approve it, and they want the patient to fit into certain boxes, have differences in multiple organ systems, or have something progressive or degenerative. So sometimes the criteria that they want to see are, things we'll have to meet if we want insurance to cover it. And sometimes I think there's a genetic condition, but the child doesn't quite fall into the little boxes.
So I know there's some ethical issues with genome sequencing. So you could just talk a little bit about what those are. And so a lot of data is collected, and sort of what happens to that data.
Right. So we need to be cognizant of the fact that really important genetic information is being generated that can have implications for not only the patient, for the family, other family members, potentially. Depending on where that test is being sent, it's making its way back to the medical record. Okay, usually, a very detailed discussion needs to take place with the family, and talk about these things. Get informed consent. They do talk with a genetic counselor before the genetic testing is done. There are implications for genetic testing, right? In terms of finding out, things that may have not been targeted, or cancer risk or things along those lines. There are protections against those things as well. There are laws in the United States that prohibit discrimination, right, based on genetic material for health insurance or employment. But not for life insurance. So there's a lot of information that's generated out of these tests, and it's sensitive information. So it needs to be handled appropriately, and there needs to be informed consent from the family as well.
So once you made a diagnosis and you got a clinical protocol for treatment in place, what happens to that data? Because it would seem that there would be a lot of potential future use of that as more information is known about different diseases, that you would want to keep that data to use in the future. Is that?
Yeah, not without informed consent. So, I mean, if the genetic test was obtained as part of a research protocol, and then you were, as part of that protocol, you also had some clinical confirmation of testing of your findings, but then you got informed consent to use the data or the remaining DNA that's left over for additional research, then that's possible. But traditionally, from a clinical perspective, if the test is sent off, there's a finding that's made, that data gets put into the medical record as a report. And is returned to the clinical team.
We're not holding the data. Like clinically, we get a report back from the test company. It tells us what they thought was important, and we don't hold the genomic data. The testing company, they have multi-page consents, and you can opt out of them doing anything with it. But often they have options to opt in for research purposes. That's protected. Protects the patient's anonymity, but often it's helpful because, as we mentioned, sometimes the test comes back negative, and then sometimes they'll reach out to me a year or two later and say, "Oops, this patient, we didn't recognize it initially, but they have a change in this gene, and now we know other patients with the same condition, and now we think it's positive." So most people don't opt out, but they can't use it for. I know, like 23andMe, sometimes that data is out there for if your nephew or somebody does something bad, and it can be used to, against them in a criminal way. This is more protected than that. So I don't think none of this is accessible to like law enforcement or anything like that. It's medically protected.
So just by way of concluding, so what's the future for genome sequencing and whole genome sequencing and rapid whole genome sequencing? Yeah.
Well, so we're actually involved with a research project right now, myself and Dr. Kalsner, along with a fantastic group of scientists over at Jackson Laboratory for Genomic Medicine. And so there are newer ways of sequencing DNA that are being developed. And we talked about whole exomes, whole exome sequencing, looking at the short coding regions. Then we talked about whole genome sequencing, and traditionally that's done by taking small segments of DNA, again, the entire genome, but piecing them all together with small pieces. Now, new sequencers are being developed that are referred to as long sequencing reads, where you can take very, very long pieces of DNA and then put them together to cover the entire genetic sequence. And it's thought that method is going to provide even better resolution to detect very small mutations and versions that may have been missed even using the traditional short read whole genome sequencing that we have been kind of talking about.
I mean, I can see a lot of ways this could this could really develop. I think we're still confined a lot by, insurance approval and steps they like us to go in doing testing for patients. So often
So
still
sorting that out.
Yeah, we often have to send smaller tests for something called a microarray, or that there's Fragile X, like a couple of tests, and then they'll want to see those before we can send whole exome sequencing. So sometimes it still feels like it takes longer than it should, and we're adding to cost probably, I think, because if we went to whole genome sequencing, it covers all this other stuff, and we really wouldn't need microarray, Fragile X, all the other individual tests we send really become kind of obsolete because whole genome sequencing really is an all-encompassing test.
Yeah. So let me ask you this one more question. So what proportion of patients for which you do whole genome sequencing, when you find a genetic abnormality, you sort of hone in on what is the causing the problem, the disease, for what proportion of those patients is there a treatment?
Well, again, it depends what we're looking at for treatment. So actual treatment, like a gene therapy or a diet change or a medication, is still a minority, I'll say. But it's growing for sure. We have gene therapy, incredible growth in spinal muscular atrophy, muscular dystrophy, really diseases that were progressive, often fatal diseases. And so there's tremendous shifts in ability to treat disease, and it's getting better and better. And there are gene therapy studies for all kinds of rare things now. So that may really develop a lot. At this point, it's still a minority. However, I think a lot of the time when we can make a genetic diagnosis, we can still understand much better how to take care of the patient as far as monitoring for other things, as we talked about before, like other medical things that might happen with that genetic condition. So it really helps us keep the patient healthier and take better care of them.
There must be a significant emotional component both for the patient and the family, right? We're just being able to understand what's going on versus being, kind of in the void, not understanding.
And a lot of time, I notice, moms get very hung up on, I fell when I was pregnant, I, had a high fever at one point, or I ate some unfermented cheese. I don't know. People come up with all sorts of explanations for what must have caused whatever their child's going through. And I think often when we can find that answer, and it's obviously nothing to do with anything. So I think there's just tremendous relief in that. And also now that everything's so global, so we may diagnose something that no one else in Connecticut has, and we can't connect them with another family, but on Facebook they can find a group that may have 50 families from across the world with a child with the same condition. And I think that really helps families to connect on a very specific and personal level and find out what's helping another child with this rare condition, how that family's doing.
Well, Dr. Matson, Dr. Kalsner, thank you both. This is very, very interesting, and it's really your work is so important. Thank you so much.
Thank you.
Our thanks to Drs. Matson and Kalsner. Our conversation with them, I believe, gives us a great sense of how valuable whole genome sequencing is in clinical settings. Its great value to patients, caregivers, and families. Thanks to all of you for listening and watching. Remember, you can listen, like, and subscribe to our podcast wherever you get your podcasts. And please leave us a review and let us know if you have any ideas for future podcasts. And for a full list of episodes, head over to CBIA.com.